Uh, when we look at what is happening today, we have to take into consideration today is the 76th anniversary of the founding of the NHS. The NHS does a huge amount of good work, but these are certainly unprecedented times for the NHS and the care sector per se. We have the greatest health emergency in the last 100 years, still apparent, whatever central government is saying, and still lurking in England. We've got different systems, as you well know, with the different assemblies and the different nations of the UK. Obviously, you will have an interest in the community hospital situation. I have to say that the community hospitals were not used in the first stage of the COVID pandemic. I asked the question of UH&M at its last board meeting and said they weren't needed, but they weren't needed for acute care. I've always argued that they will be needed for rehabilitation, and there's been movement on that since. The fact of the matter is that COVID, the pandemic, and we will have more pandemics in the future, they're occurring at faster rates. The pandemic has exposed fault lines in our society and exposed our vulnerabilities. Sadly, there's been nearly criminal incompetence on high from central government. The PPE saga, which is absolutely atrocious, sending frontline staff, and I include frontline staff being care home staff, into dangerous situations without the correct equipment for protection, has caused deaths amongst those staff. When we relate it to how other nations have dealt with this, where we know that in Germany, for instance, there hasn't been a death within their health system of frontline staff, and there hasn't been a death in their care home system of frontline staff. That was the latest stats we've got from Germany. Right, for the present, at this moment in time, where are we? Well, the concentration tends to be on acute hospitals. Well, if we look at what happened with acute hospitals, the NHS has actually dealt with, within its capabilities in England, has dealt with COVID to the best of its abilities, but there have been consequences. The way to relate COVID into our society is not look at COVID deaths, is to look at excess deaths. And the excess deaths that are coming from the ONS are quite shocking. When we look at the hospitals, the hospital alone, we look at their performances in comparison to prior to COVID, and remember that we were on, even then we were on unprecedented times, because the impact of austerity was impacting on the NHS and the care sector per se, very much so in social care. We had nearly a perfect storm in the winter. Look back in December, and the NHS was finding it very, very difficult to cope. And then, of course, COVID arrives. But when we look at what has happened during the COVID pandemic, and I'm looking at UH&S figures, emergency attendances have dropped 50%. Elective activity is only 16% of what it was previously. Outpatient appointments are only a third of what they were previously. Follow-ups were approximately 50% of what they were previously. And then when we look at UH&S, the hospital situation per se, what we're talking about is sickness and absence, which doesn't surprise us, or shouldn't surprise us, because the stress on NHS frontline staff in the hospital situation alone has seen a 50% increase. So that is the impact of COVID per se in a stark reality. When we look at what is happening with other factors, we know that the referral to treatment, the waiting lists in England, which started off at around 4.5 million in February, probably past 6 or 7 million now, and are online, people waiting for care or prompt services from the acute sector, and that's the acute sector alone, probably reach about 9 million by December. How has this been counteracted? Now, we see today Simon Stevens was interviewed, I believe, on BBC TV. And we have got information that the NHS actually, 400 million in England, have contracted with the private hospital sector at a cost of £400 million per month to restart electives. We now know that PPE, which is the required equipment for frontline staff, both in the NHS and the care sector, per se, care homes, that of itself has costed now at £14 billion for the whole year for the NHS. We now know that the care home sector itself is still struggling with PPE and access to PPE, and we also know that testing is problematic in the NHS. Now, we've got the announcement of a world exemplar for test and trace. Some wag in the NHS called it test and trace. The acronym is TAT, T-A-T, and we all know what TAT is. It is not functioning correctly. We know that people were discharged into care homes. And don't forget our policy of our CCGs that was taken in January was that AIRS, adult inpatient rehabilitation services, we close 184 community hospital beds, we'd replace them with about 50 care home beds, and that would suffice. But we know that people have been discharged, medically fit for discharge, from hospitals into care homes locally, and they were carrying COVID. We know that for a fact. Between the 15th of March and 15th of April of 2020, this year, there were 694 people discharged from UHM into care homes. 125 of those people were tested. That means 75% were not tested. And 54 people actually were tested positive for COVID. Now, we're fairly certain that these people went into Bradwell Hall, for instance, and we know there have been deaths in Bradwell Hall. And Bradwell Hall was one of the main providers of AIRS, subacute services, that was commissioned by the CCGs throughout the campaign for keeping community hospitals and this year. So where are we now? Well, actually, there's something positive that's starting to appear around care. In Surrey, they have now commissioned, the NHS has now commissioned, what are called SEACOLE beds, SEACOLE. 300 have been commissioned, and why they've been commissioned is people who have COVID and end up in intensive care will need intensive rehabilitation. 300 in Surrey. Surrey has a population equivalent for the whole of Staffordshire, including Stoke-on-Trent. We were relying on 70 at the Hayward for our 500,000 people in the northern Staffordshire area, plus 50 in the care home sector. Now, the care home sector quite obviously cannot cope with, and it's quite obvious, they cannot cope with the amount of the infection that they're going to get from COVID. First wave, there'll be a second wave, there'll be other waves, and they cannot cope with rehabilitation. So there's a move towards setting up equivalent of community hospital beds in Surrey. The Northwest region themselves have argued that they need 900 SEACOLE beds. So there is potentially a future for Bradwell, I would say Leek. I'm not so sure about Cheadle, so there is potentially a future for those community hospitals. But of course, when we're looking at COVID, it has exposed the flaws and the fragmentation within our care system. Acute, sometimes there's a semi-permeable membrane around acute that doesn't really know or have knowledge of community, which doesn't really have knowledge of primary care, which is your GP services, which doesn't really have knowledge of social care. There is a need for a holistic approach to care. I believe the community hospitals have got a future, but we can't carry on as we've been as we have in the past. A sector, having its budget, having to live within fiscal constraints, having to live within fiscal constraints, having to live within fiscal constraints. We have to have a whole approach. And I welcome integrated care systems, but I'm not sure that it's working towards a whole approach as we need it. Can I leave it there for the moment, Thomas? Is that okay?
Yeah.